Good morning, everyone. I'm Carl Diefenbach, the Director of the Division of AIDS at the National Institutes of Allergy and Infectious Diseases. We're here at the University of Washington today to talk about a very important study called Reprieve, which is a heart study, and that's why we're sending this out to you on Valentine's Day. So I'm joined by three people who are excited about the clinical study Reprieve. They're going to introduce themselves now.
Hi, I'm Kelly, and I work for the YWCA in Seattle. And I am HIV positive, and I love the fact that women are being included in the Reprieve study.
My name is Dwayne Whitus. I have severe hemophilia A. I was diagnosed with HIV in 1986, so it's been a long and interesting journey, and my goal is to die a very, very old man. So anything that we can do to help along that goal, I'm in 100%.
My name's Abe Gaston, and I am the Community Advisory Board Representative for UW-ACTG. And I'm interested because I recently went through the process of having a heart attack.
That's an interesting, the reason we're performing the Reprieve trial, as you know, is that people with HIV are about a twofold or 100% increased risk of having cardiovascular events as a side effect of their HIV. And as great as the antivirals are today, we still have a little bit of excess morbidity and mortality that doesn't quite get us the normal lifespan we're looking for. So the Reprieve trial will help us get there. So tell me a little bit about what it was like to enroll in the trial for you.
Well, for me, it was pretty simple. It was streamlined. I was contacted by the ACTU because I am female and because over 40, and I do have some obvious, issues as far as morbid obesity. And so being positive and having morbid obesity, I was already at risk for heart disease, even though I don't have any of those factors, right? But just because of that, it was of interest to me to be part of this study to see if anything comes out of it that would help me make better decisions for my health.
And I was recruited through the Madison Clinic, and since going on retroviral therapy, I've watched my cholesterol creep up into the danger zones over the years, getting a little older, and it seemed like a simple enough process to be part of.
So as a CAB member, you've participated in clinical research before?
Yes.
So can you tell us a little bit about how your journey to become a CAB member and to then really help with recruitment, and also to make sure the UW stands as one of at the forefront of high quality patient-centered research?
Well, the reason I personally became a CAB member because, well, I was asked. There was this process they were going through, and they wanted to bring the community together to put more information into the community about HIV. Michael Luella, he's on several different CABs and as coordinator, and he said, would you be interested in learning more about this? And I said, yes, I was. So ultimately, as I was thinking about joining some of the studies, I've been on some of the studies 5-6 years. Even longer. And then, of course, when I had the heart attack, that put me out of the game for the Reprieve study, primarily because you kind of need this kind of medication, and the Reprieve study basically says, well, we don't know if you're going to get it or not, so we can't take you off it because it's something that's mandated for you.
Yes, yes. I think that's an important point. So to participate in clinical research, you've participated. Had you participated? Either of you participated in clinical research before?
Yeah, I've done clinical research before, although nothing with medication. It was always just a study for different purposes, but nothing with medication.
Very much the same way. Being part of the hemophilia community, they're always recruiting us for some joint study or a mobility study or something, but this is the first time also with any kind of medication.
So once you joined Reprieve, how was it for you to take 2 pills a day instead of once a day?
Well, I actually take more than that.
Oh,
So
That's important.
that
So-
is very
so you
important.
still added an additional pill to your daily
I
regimen.
just added one more pill to my regimen of 6, so it didn't phase me.
And as a hemophiliac, you're probably taking a lot more than one pill a day.
Well, for hemophilia, it's all an IV injection,
I
so
see,
I
so-
do that a couple of times a week. But same way, I just added it to my regimen of all the other pills. I put them in a shot glass and fire them down at night with a big old glass of water.
That's the way to do it. And you having had a heart attack, you're probably, in addition to being on statins, some of the other drugs that help your heart heal and repair. I have to ask the question, how are you feeling these days? Are you back to where you were? Or is your health back to normal?
Well, after I had the heart attack, medication adjustments is going on almost 2 years now, and I'm still in the process of medication adjustment. One of the times when I first had it, I was up to 20 pills a day. So that got a little bit much.
Yeah. So, I mean, coming back to the purpose of Reprieve is to really make it so that patients will be able to have access to a medication like a statin, even though they're not. It will help us get to a place where we change the guidelines so that an HIV positive person, if this trial is successful, would have access to a statin, and it would then help prevent others in the future from having a heart attack. So as we go forward, what are your expectations out of the trial? Clearly, my expectations are I want a sufficient number of women and men to enroll so that we are powered, we can see a positive benefit and get an answer for both men and women who are HIV positive. So that's my major goal.
Well, I think that's actually my goal too, is to not only personally, but also because I do work with HIV positive women, it's really important to advocate for clinical trials that are open to women. And not only that, but for heart health and, just personal physical health, period. I think for myself, I really am honored to take part of this. Because it will help further my own health, but then the health of others.
Terrific.
I'm kind of a data nerd. I am just growing up in the HIV community. There was so much anecdotal information always bantered around about cures and treatments, and oftentimes that data was practically non-existent. So in any of these kind of situations, the more data we can have, the more we can study, the more we can sort of direct people. I don't believe that medicine's a one-size-fits-all sort of science, but the more data we have, the more we can tailor that to the individual and get people living longer and better.
I feel that being the CAP representative, I like to talk to a lot of people about what's going on. I think ideally it would be wonderful if everybody knew. Unfortunately, everybody doesn't have the access to know. And a lot of times it's not because of the information isn't being put out there. Sometimes it's the location of where the information is that people neglect to go to. I think that we need to kind of work on getting it out to the main populace, because like everybody goes to Starbucks, but not everybody goes to, the hospital. And even though there's a lot of people that go to the hospital, everybody don't go to certain sections of the hospital. Yeah. So I think putting it out really, really matters, and it'll really make a big difference once we have the opportunity to put it out more into the general public.
Your point is really important, and I think as a CAB member, your insights into how we can reach into community better will be very important. I mean, because King County and the University of Washington have been leaders in this, but we really struggle. It's not just here, but it's around the globe, reaching the potential participants, because we sit in our offices and we work in hospitals, but we're not necessarily out in the community the way we can truly understand. So any other insights you have, Starbucks is a great idea, buses are another idea, but in general, the strength of a CAB is its ability to go out and talk to the community and participate. And all of you, through participating in this today, will hopefully reach a new round of participants. So I thank you. So just one last question. As you have been living with HIV, how have your medications changed over the years? Have you gotten safer and better for you? If they have, what has your experience with side effects? Are things better for you today than they once were? Or
I
tell
would
us about your journey.
Yeah, I would say definitely it's night and day difference. When I first started, it was AZT, 24 years ago, and I've gone through the progression of different medication regimens, and to be on a one pill a day for HIV treatment, that it's amazing. Side effects, there's almost none with Genvoya, and I just came off of another once a day pill regimen, and that was not that bad as far as side effects. Now I have none. So I think it's amazing.
Exactly the same. I started off on the AZT back in the late 80s, early 90s. I guess it was the early 90s, and it was horrible. I felt run down and just generally not healthy. A trip to the hospital, and I ended up stopping my AZT regimen and never felt better after that. Then I got really lucky and went for close to 20 years without having to have any therapy at all until my T cells dropped and my viral load went back up. And by then it was the once a day pills that, and with zero side, really kind of weird, interesting dreams sometimes. But other than that, yeah. So other than that, nothing to complain about. And some of those dreams are pretty awesome.
Well, fortunately for me, it's been one pill a day. The only time it was different was because I was on a trial and they added additional pills to, because of the trial sake. But once that was over, it's been one pill a day. No side effects per se. I think that's generally because of the people that I work with here at the ACTG. They're well informed, and so prior to me doing anything, we have a discussion. I'm able to say yes or no or ask a million questions and get the information I need, make that decision, and move on.
So as we get set to close this discussion about the Reprieve trial, these are three fascinating people, all with wonderful stories about how the use of antiretroviral therapy has put them in a very good place in their lives. Now, by advancing HIV science to deal not just with HIV, but also with the non-infectious comorbidities such as preventing cardiovascular disease, we hope to extend and expand the quality of all patients living with HIV's lives. So here from Seattle, I want to thank you. Happy Valentine's Day to all of you.
Happy Valentine's Day.
And thank you for all you do as a participant. And I give you my pledge that I will continue to work until I put myself out of a job, because HIV will be history. Thank you.